Imagine the scene. A tiny, fragile newborn foal, just days old, perfectly fine one moment, then suddenly its world is turned upside down by a seizure. It's terrifying, an urgent medical emergency.
Yeah.
And when you see something like that, your mind immediately jumps to the question, what just happened?
Precisely. Because a seizure in a foal isn't just a single isolated event. It's a profound window into the incredibly delicate physiology of newborn equines.
Right.
And it's a clear signal that something significant is disrupting it. It's truly a critical neurological crisis.
And today, that's the complex world we're diving into, foal seizures. You've provided us with, well, a stack of incredibly detailed sources, articles, cutting-edge research, clinical observations, and our mission is to unravel it all. We'll explore everything from the fundamental mechanics of what a seizure actually is to the surprisingly diverse range of underlying causes, how veterinarians become like medical detectives to diagnose them, the advanced treatments available, and what the future holds for these vulnerable foals. Think of this as your shortcut to truly understanding this critical area of veterinary medicine.
So let's start at the very beginning. What exactly is a seizure? Our sources define it as a transient episode of uncontrolled electrical activity within the brain.
Like an electrical storm.
Kind of, yeah. Think of it like a sudden, chaotic electrical storm in the brain.
Yeah.
This abnormal activity then leads to observable changes in a foal's behavior and consciousness.
Okay.
While seizures are relatively uncommon in adult horses, their occurrence in foals is a major red flag. It signals severe underlying distress that needs immediate attention.
And these brainstorms aren't all the same, are they? They manifest in different ways depending on where that uncontrolled activity starts in the brain.
That's a crucial distinction. The most common type we see in horses are generalized seizures.
Okay.
As the name suggests, these involve widespread abnormal electrical activity across large portions of the brain, leading to full-body manifestations.
So you'd see things like,
You might witness a sudden collapse, violent limb paddling, almost like the foal is trying to run while lying down.
wow,
And something called opisthotnos.
opisthotnos.
Yeah, that's a severe arching of the back with the limbs rigidly extended.
Then there are focal or partial seizures. These sound more localized.
Exactly. They originate in a specific, smaller area of the brain. The initial clinical signs are confined to a particular body part.
Like what kind of signs?
Maybe subtle facial twitches, rapid eye movements, or repetitive actions such as compulsive chewing or suckling motions. It's important to remember that sometimes these focal seizures can actually spread and escalate into generalized seizures.
Ah, okay. So they can start small and get bigger.
They can. And if they involve impaired consciousness, where the foal seems unaware of its surroundings, they're specifically called complex partial seizures.
Got it. Now, you mentioned a seizure isn't just one continuous event. There are phases.
That's right. It typically progresses through 3 distinct phases. First, there's the prodromal or preictal phase.
Preictal, before the main event.
Exactly. This is often subtle, non-specific changes that can occur hours or even days before the active seizure. That's mood shifts, increased anxiety, or just, an altered demeanor.
But not always obvious.
No, it's worth noting that not all foals will clearly show this stage.
Okay, so phase 1 is preictal. What's next?
The second phase is what we call ictal phase, which is the active seizure period itself.
The actual seizure happening.
Right. This spans from the very first symptom until that abnormal electrical activity in the brain finally stops. During this phase, you might see foals lose awareness, become confused, or have altered sensory perceptions, perhaps reacting to unusual smells or sounds that aren't there.
And the physical signs.
Motor signs can range from difficulty vocalizing, twitching, loss of muscle control, or repetitive movements like lip smacking, all the way to full-body convulsions.
Okay.
You might also observe changes in vital signs, like a racing heart rate. For those dramatic, generalized seizures, this is where you'll see the sudden collapse, the violent limb paddling, or that severe back arching.
And after the ictal phase, the storm passes.
Then comes the post-ictal phase. This is the recovery period right after the active seizure.
How long does that last?
It can vary wildly in duration, sometimes minutes, sometimes hours, or even days, depending on the seizure's severity. Common signs here include confusion, disorientation, profound tiredness.
Exhaustion, I imagine?
Definitely. Or even a loss of bladder or bowel control. A frequently observed postictal sign in foals is cortical blindness.
Cortical blindness? What's that?
It's fascinating, actually. Their eyes look structurally normal, but the foal is temporarily visually impaired because the part of the brain processing vision isn't working right.
But it gets better.
Our sources say this often resolves spontaneously within 24 hours.
So why is rapid intervention so absolutely critical when a foal starts seizing? What's the immediate danger?
It's a medical emergency, primarily because those uncontrolled, often violent movements pose a significant risk of physical injury to the foal itself.
Like hitting their head.
Exactly. We're talking severe head trauma, corneal ulcerations from rubbing their eyes, and potentially life-threatening aspiration pneumonia if they inhale fluids or saliva.
Right.
And let's not forget, these erratic movements also present a substantial danger to nearby personnel and other animals in the barn.
That makes sense. Beyond the immediate physical trauma, I understand there's a more insidious danger happening inside the brain when a seizure continues unchecked.
That's absolutely right. Uncontrolled seizures dramatically increase the brain's demand for oxygen.
More than usual.
Way more. And if a foal is already experiencing some form of brain injury, this increased demand can severely exacerbate it. It creates a dangerous, self-perpetuating cycle of damage if not addressed quickly.
So stopping the seizure quickly is crucial to limit that secondary damage.
Exactly. Every second counts.
What makes recognizing these seizures so challenging for owners and even vets? It sounds like it's not always a dramatic, obvious event.
You're exactly right. They can manifest across such a wide spectrum, while some are unmistakable, like those dramatic convulsions.
The ones everyone pictures.
Right. Others can be incredibly subtle. Maybe just slight behavioral changes like aimless wandering, a decreased suckle reflex, or even a diminished bond with the mare.
Things you might almost miss if you weren't watching closely.
Precisely. And to make it even harder, many affected foals can appear neurologically normal between episodes.
That makes it tricky.
It really does, which further complicates early and accurate recognition. This really highlights the vital importance of a detailed history from caretakers, noting any subtle deviations from normal behavior, no matter how minor they seem.
Because they're often the first to notice something is just off.
They really are.
So if a vet sees a foal seizing, they're not just looking at one problem, are they? It sounds like it's the tip of an iceberg, a signal that something much deeper is going on.
That's the perfect analogy. A seizure in a foal is rarely a standalone issue. It's a critical clinical sign, and unraveling its root cause is like piecing together a complex medical puzzle.
And the causes are pretty varied.
Remarkably diverse, yes. And understanding them is absolutely key to effective treatment.
Okay, let's dig into those causes. Let's start with what our sources identify as the most common non-infectious central nervous system, or CNS, disorder in newborn foals.
That would be neonatal encephalopathy, or NE. You also hear it called hypoxic ischemic encephalopathy, HIE, or perinatal asphyxia syndrome, PAS. Lots of names for it.
NEHIEPAS.
Got it. And that's linked to oxygen deprivation.
Often, yes. It's frequently linked to impaired oxygen delivery, which we call hypoxia, and/or reduced blood flow or ischemia to the brain.
When does that happen?
This can happen before, during, or immediately after birth.
And when the brain is deprived of oxygen or blood flow, how does that actually cause damage? What are the key processes happening at like a cellular level?
It's a cascade, really. There are several key mechanisms. First, without enough oxygen and glucose, brain cells experience energy failure.
They run out of fuel.
Essentially, yes.
Yeah.
They can't produce the vital energy molecule, ATP, that they need to function, leading to cellular dysfunction. Second, we see excitotoxicity.
Excitotoxicity. Sounds bad.
It is. This is where specific brain cells become overstimulated, leading to an excessive influx of calcium into the neurons.
Too much calcium.
Yeah, this calcium overload, exacerbated by excitatory compounds like glutamate, literally overwhelms and damages the neurons. They kind of work themselves to death.
Wow, okay, so energy failure, excitotoxicity, what else?
Then, paradoxically, when blood flow is reestablished, you can get free radical injury. It's also known as reperfusion injury.
So getting blood flow back can cause more damage.
In a way, it's a burst of highly reactive, toxic compounds that are released and cause delayed neuronal death, sometimes hours or even days after the initial insult.
That's tough. Anything else in this cascade?
There's also a significant inflammatory response within the brain. Specialized immune cells called microglia get activated and produce pro-inflammatory compounds that just exacerbate the damage.
And I think you mentioned something newer involving neurosteroids.
Yes, what's particularly fascinating and a newer area of research is that abnormal concentrations of certain natural compounds, like neurosteroids such as progestogens, may also play a role. This is opening new avenues for understanding and potentially treating NE.
That's a lot of complex interactions. So, what puts a foal at risk for this whole cascade of events leading to NE? What are the risk factors?
It's definitely multifactorial. We can categorize them. Maternal factors include things like respiratory disease in the mare, endotoxemia, that's a serious bacterial toxin in the bloodstream, often from colic,
Okay.
or things like C-sections. Placental factors are huge. Premature placental separation, the red bag delivery,
I've heard of that.
yeah, where the placenta detaches too early,
Hmm.
or placentitis, which is inflammation or infection of the placenta,
Yeah.
or just general placental insufficiency like you might see with twinning or fescue toxicity.
And from the foal side.
On the fetal side, risks include malformations, hypovolemia, that's low blood volume, maybe an excessively long umbilical cord, and twinning again.
And the birth itself.
Absolutely. Peripartum events are critical. Difficult births, called dystocia, very rapid deliveries, or even oxytocin induction. All of these can potentially contribute to oxygen deprivation during that critical birth period.
It sounds like NE isn't just a brain problem then. Does it affect other parts of the foal's body too?
It absolutely does.
Mm.
And this is critical to stress. Perinatal asphyxia, that initial oxygen deprivation, doesn't just impact the brain. It can affect multiple organ systems.
Like which one?
Foals with NE can also exhibit significant issues with their kidneys, heart, gastrointestinal tract, think colic or ulcers, lungs, liver, and their endocrine system.
Wow, it's systemic.
It really is. This widespread multisystemic impact underscores the necessity of a comprehensive physical examination to identify and address all concurrent issues, not just the neurological ones.
This brings us to the distinctive dummy foal phenomenon, which is probably what most people think of when they hear about NE or HIE.
Right, the maladjustment syndrome.
These foals exhibit really inappropriate behaviors like failing to find the udder or suckle properly, aimless wandering, or a surprising lack of affinity for the mare.
Yeah, they just don't seem to connect.
What I find truly intriguing, and you touched on this, is that many affected foals often appear entirely normal at birth, only to develop clear neurological abnormalities hours or even days later.
That delayed onset is due to those complex secondary neuronal injury mechanisms we just talked about, the inflammation, the reperfusion injury.
It really makes you wonder, doesn't it, how closely we should be monitoring all newborn foals, even after births that seem totally uncomplicated.
It truly does. Vigilance is key in those first few days. And historically, NE was almost exclusively linked to those clear, acute oxygen deprivation events during birth.
But that thinking is changing.
It's broadening, yes. Recent research indicates that not all cases have a clear history of such an event. Emerging theories suggest that maybe a systemic inflammatory response in the fetus, perhaps from an intraquarterine infection like plantitis.
So information before birth.
Potentially.
Yeah.
Triggering pro-inflammatory compounds that then cause brain injury. This expanded understanding suggests a need for more diverse diagnostic investigations and opens new avenues for novel therapies beyond just traditional resuscitation efforts.
Okay, moving on from NE. While it's less common, infections of the central nervous system can be severe and life-threatening for foals.
They certainly can. Bacterial meningitis or meningoencephalitis, inflammation of the brain and its coverings, are thankfully infrequent. But when they occur, they can have high fatality rates in foals.
What kind of bacteria are usually involved?
Common culprits include E. coli, Salmonella species, Streptococcus species, and Actinobacillus E. coli. We also consider Clostridium pilliform, which causes Teeser disease.
Teeser disease.
Yeah, it causes severe liver damage, which can then lead to hepatic encephalopathy, brain dysfunction due to liver failure and seizures in young foals, usually under 45 days.
How do these infections actually get into the foal's brain? What are the routes?
In several ways. The most common is hematogenous spread.
Through the blood.
Exactly. Bacteria travel through the bloodstream, often secondary to an overwhelming systemic infection we call sepsis.
Okay.
A foal's susceptibility to this is significantly increased if they've had a failure of passive transfer FPT.
Meaning they didn't get enough colostrum, the first milk.
Right. Didn't get enough protective antibodies from mom. Infections can also spread by direct extension from adjacent sites, like a sinus infection, an ear infection, even guttural pouch issues or bone infections nearby.
Makes sense.
Of course, penetrating wounds can directly introduce bacteria, and even the umbilical cord can be a direct portal of entry for bacteria, sometimes even without obvious GI signs, like in some Salmonella typhimurium cases.
And what are the signs of these CNS infections? What should people look out for?
Clinical signs can vary depending on the stage and location of the infection, but they often include altered mental status, anything from apathy to deep depression, recumbency, being down and unable to rise.
Weakness.
Yeah, weakness, abnormal pupillary reflexes, diminished suckling, seizures definitely, nystagmus,
That's the repetitive eye movement.
right, involuntary eye movement.
Mm.
Also ataxia, that lack of coordination, making the foal appear wobbly, anorexia, blindness, head pressing against things, and often fever.
Then we have viral infections. I know in adult horses, certain mosquito-borne viruses can cause serious neurological issues. Is that true for foals too?
Yes, absolutely. We worry about viral encephalitis, particularly from arboviruses like Eastern, Western, and Venezuelan equine encephalomyelitis E, WE, and V.
The sleeping sickness viruses.
Exactly. These are serious mosquito-borne viruses that cause severe inflammation of the brain.
Yep.
And it's important to remember they're transmitted only by mosquitoes. They don't spread directly horse to horse or horse to human.
Good point. And birds and rodents are reservoirs.
Often, yes. Signs include moderate to high fever, severe depression, hence sleeping sickness, anorexia, behavioral changes, impaired vision, circling, head pressing, muscle twitches, difficulty swallowing, paralysis, and ultimately convulsions and death.
What are the survival rates like?
They vary significantly. EE can be up to 90% fatal. VE is also very high, 50–90%. DE is generally lower, under 30% mortality. We also have to include EHV1, equine herpes virus 1, which can cause neurological disease in foals as well.
Are there other types of infections besides bacterial and viral?
Yes, we also consider protozoal and fungal infections. Equine protozoal myeloencephalitis,
Right.
or EPM, is a significant one.
EPM. I've heard a lot about that in adult horses.
It affects foals, too. It's caused by Sarcocystis neurona, typically from opossum feces or sometimes Neospora ukase. Horses are considered dead-end hosts for S. neurona, meaning they get infected but don't spread it further.
And the signs of EPM?
Highly variable. It can mimic many other neurological diseases. Common signs include asymmetric ataxia, wobbliness that's worse on one side, weakness, muscle atrophy, head tilt, difficulty swallowing, facial nerve abnormalities, and yes, seizures can occur.
Is there anything that helps distinguish EPM?
A key feature is that affected horses are often not painful or feverish, which helps differentiate it from bacterial meningitis, for example.
It sounds like sepsis is a really big deal for foals, not just for general health, but specifically for the brain.
It is absolutely paramount. Systemic infections, especially sepsis, that overwhelming whole-body infection, are major predisposing factors for CNS complications.
So treating sepsis quickly is critical for the brain, too.
Critical. Aggressive and timely diagnosis and treatment of sepsis are vital not only for the foal's overall survival, but specifically for preventing these severe neurological sequelae. It's truly a race against time.
And some of these pathogens sound like they could jump from horses to humans. Is that a concern on a farm? Zoonotic potential.
That's an excellent question, and it's a very real concern. Pathogens like Salmonella and the arboviruses we mentioned, E, W, E, V, E, are zoonotic, meaning they can affect humans too.
So biosecurity is key.
Absolutely. This emphasizes the vital importance of stringent biosecurity practices on farms. Things like proper vector control for mosquitoes, careful disposal of contaminated manure, and strict hygiene practices to protect both equine and human health.
And diagnosing these infections must be tough with overlapping signs.
It is. The diagnostic challenge for all infectious causes is that clinical signs often overlap. Protozoal causes, for example, often lack fever or pain. So definitive diagnosis usually requires specific laboratory tests like CSF analysis, analyzing the cerebrospinal fluid, or sometimes, unfortunately, a postmortem examination.
Okay, let's shift gears. Beyond infections, I understand that sometimes the problem isn't external, but an internal chemical imbalance. Let's talk about metabolic imbalances.
That's right. Metabolic arrangements can profoundly impact neurological function, directly leading to seizures. These are often what we call acute symptomatic seizures.
Meaning the seizure is a symptom of the imbalance.
Exactly. They are a direct consequence of the imbalance, rather than primary epilepsy originating in the brain itself.
So what are some of the most common metabolic issues in foals that can trigger seizures?
The most common metabolic derangement in neonatal foals, and a direct cause of seizures, is hypoglycemia, or low blood glucose, typically under 50 mg/dL.
Why are foals so prone to low blood sugar?
Neonatal foals have very limited glycogen reserves stored glucose, so their blood glucose can rapidly plummet without adequate feeding. This is especially true for weak, sick, or septic foals.
Interesting. I noticed our sources seem to differ slightly on how common hypoglycemia is as a cause.
Yes, what I find particularly interesting here is that while one of your sources notes that low blood glucose is a common cause of seizures in newborn foals, another source classifies hypoglycemia as a rare cause.
Well,
This highlights the ongoing nuances and different perspectives in understanding these complex conditions. It's also worth noting that both hypoglycemia and, less commonly, hyperglycemia, high blood glucose at admission, have been linked to a poorer prognosis.
are there other electrolytes or chemicals in the blood that can cause problems if they're out of whack?
Absolutely. Hypocalcemia, low calcium, and hypomagnesia, low magnesium can directly lead to CNS irritability and induce seizures.
Low calcium, low magnesium.
Right. Our sources note that a physiological drop in serum calcium is actually normal in the first few days of life, but problematic levels are different. Then there's hyperammonemia.
High ammonia, where does that come from?
Elevated ammonia in the blood, often from severe liver dysfunction, causing metabolic encephalopathy. This can be seen with congenital portosystemic shunts, abnormal blood vessels bypassing the liver, or with Tisser disease. And persistent hyperammonemia is even suspected to be an inherited disorder in certain Morgan foals.
So it's not just the levels themselves, but how quickly they change. I think you mentioned that earlier, too.
That's a crucial point. Other critical electrolyte derangements, like disorders of sodium, low sodium hyponatremia, or high sodium hypernatremia, can profoundly affect brain function. And yes, it's important to remember that rapid changes in these electrolyte concentrations are far more likely to induce seizures than gradual ones.
And treatment-wise, just giving anti-seizure meds isn't enough here.
That's a crucial treatment insight. These metabolically induced seizures often cannot be controlled effectively with anticonvulsant drugs alone.
So you have to fix the underlying problem.
Exactly. Rapid identification and correction of the specific metabolic imbalance, perhaps through IV fluids, giving dextrose for low sugar, or specific mineral supplementation, is absolutely paramount for seizure control and preventing permanent brain damage.
Which means blood tests are essential right away.
Absolutely. Comprehensive blood work, including glucose, calcium, magnesium, and a full electrolyte panel, is an integral part of the initial diagnostic workup.
That makes perfect sense. The brain is so sensitive, so if a foal is seizing due to a metabolic issue, you're looking beyond just the brain at organs like the liver and kidneys.
Exactly. Liver and kidney dysfunction significantly influence a foal's overall metabolic status and neurological health. The brain is exquisitely sensitive to these systemic metabolic disruptions.
So you need the full picture.
Yes. Therefore, a seizing foal requires a thorough systemic evaluation beyond just neurological signs, including tests for liver and kidney function. And to circle back, the unique physiological vulnerability of neonatal foals to hypoglycemia due to their limited glycogen stores really underscores the vital role of proactive nutritional support, early and consistent feeding, whether orally or via IV dextrose if needed.
Now let's talk about something that can be a real hidden danger on a farm. Toxic causes. Things foals might ingest.
Indeed. Ingestion of various toxins, particularly certain neurotoxic plants, can induce seizures.
What are some common ones to watch out for?
Some common culprits include poison hemlock. Its neurotoxins affect the brain and nervous system, causing rapid onset like 15 minutes to 2 hours of muscle tremors, excessive salivation, incoordination, and seizures, often fatal.
Wow, that's fast.
Water hemlock is even more toxic. Its roots contain a potent toxin called sicutoxin. Signs can appear within an hour, leading to convulsions and sometimes death in just 3 hours.
Scary stuff. What other plants?
We also have Jimson weed, containing tropane alkaloids. It can cause anxiousness, confusion, difficulty eating or drinking, muzzle tightness, tongue protrusion, and constant chewing motions.
Okay.
Bracken fern, if ingested chronically over time, can lead to a thiamine vitamin B1 deficiency. Symptoms might not show up for winter months, but can include muscle spasms, stumbling, staggering, circling, and seizures.
So that was more of a slow burn.
Right. Loca weed, found mostly in the western U.S., contains a neurotoxin called swainsanine. It causes ataxia, congenital defects, temperament changes, and dangerous behaviors. It's actually an uncommon cause of seizures in foals specifically, but still a neurotoxin.
And yellow star thistle.
Yes, yellow star thistle or Russian knapweed cause a condition called chewing disease, nigropalatal encephalomalacia, technically. Signs include anxiousness, confusion, the tongue hanging out, and those constant chewing motions again.
Are there other non-plant toxins to worry about, things they might get into?
Yes. Other toxins to consider are ionophores, which are sometimes found in certain feed additives meant for other species. Organophosphates, which are in some pesticides, can cause excitability, tremors, drooling, and convulsions.
Nasty.
Also strychnine, metaldehyde, found in slug and snail baits, moxidectin, an equine dewormer if overdosed, and even moldy corn can contain mycotoxins that affect the nervous system.
And accidental injections.
Yes, a less common but acute cause can be accidental drug injection into the carotid artery in the neck, which can cause immediate, severe neurological signs, including seizures.
So prevention is key here, managing the environment.
Truly key. Proactive environmental and forage management is critical. Regular inspection and removal of poisonous plants. Education for owners on identifying common toxic plants in their region and carefully monitoring feed sources is also vital.
And the diagnostic challenge with suspected toxins is that the clinical signs often overlap with other neurological conditions, right? Making it hard to pinpoint the cause without specific tests.
That's exactly right. A thorough history about the foal's diet and pasture access is the essential first step. And then toxicological screening of samples, maybe feed, water, suspected plants, blood, or stomach contents, is absolutely crucial to confirm the diagnosis and guide treatment.
And just circling back to the metabolic point quickly, you mentioned serial monitoring.
Yes, and it's a key point for any critically ill foal, especially those with metabolic issues. These derangements are dynamic, they change. So serial monitoring of blood parameters like electrolytes and glucose is essential, as they can fluctuate rapidly. This proactive monitoring is key to preventing recurrence of metabolically induced seizures.
Now let's talk about physical injury. Traumatic brain injury, or TBI, head trauma.
This results from direct physical trauma to the head, leading to damage to brain tissue, blood vessels, and nerves.
How does that usually happen in foals?
Common types include pole impact hitting the back of the head, often from a foal flipping over backwards, or frontal parietal impact from running into fixed objects like a wall or fence. Less directly, temporal hyoid osteoarthropathy, or THO, a condition affecting the jaw joint area, can also contribute to neurological signs if it leads to fractures nearby.
And what kind of damage does TBI cause inside the head? Skull fractures.
TBI can result in various brain lesions like skull fractures, yes. But it's important to note that severe brain injury doesn't always involve an obvious skull fracture, and vice versa. Sometimes a fracture is there with less severe signs.
Okay, so what else?
There can also be intracranial hemorrhage that's bleeding within the brain, or skull-brain edema swelling that leads to increased pressure inside the skull and contusions, which are essentially bruises on the brain tissue itself.
And the signs, are they always obvious?
Clinical signs range from acute and severe, like fainting, seizures, sudden blindness, bleeding from the nose or ears, unresponsiveness, recumbency, to more subtle and delayed signs, such as headaches, confusion, dizziness, blurred vision, or temporary behavioral changes.
It's pretty amazing how severe brain injury doesn't always have an obvious skull fracture, and subtle head trauma can be easily overlooked. This makes me wonder, how do vets even suspect TBI if there's no clear sign of trauma?
That's a crucial insight and a real challenge sometimes. TBI should indeed be suspected even without overt signs of trauma. A thorough history of any traumatic event, no matter how minor it seems, combined with a comprehensive neurological exam, is absolutely essential.
And the damage isn't just immediate.
No. Beyond the immediate mechanical damage, significant neuronal death actually occurs hours to days later due to those secondary processes we talked about earlier: oxidative stress, excitotoxicity, inflammation, and reperfusion injury.
That cascade again.
Exactly. And these are all compounded by physiological derangements like abnormal blood pressure, temperature, glucose, and oxygenation. Therefore, aggressive supportive care to maintain physiological homeostasis, keeping all of those body systems in balance, is paramount in the immediate post-trauma period to prevent this cascade of secondary damage.
Is there anything that helps predict the outcome with TBI?
The duration and progression of recumbency, being down and mental stupor, are considered the most important indicators of seriousness. Foals remaining recumbent for more than 4 hours after injury are significantly less likely to survive, which gives a guide for prognosis.
Our final category of causes covers congenital brain malformations and inherited disorders. These are structural defects present at birth or genetic issues that lead to neurological signs and seizures.
Right. Examples of malformations include hydrocephalus.
Water on the brain.
Essentially, yes. An abnormal increase in cerebrospinal fluid volume within the brain ventricles. It can sometimes lead to a dome-shaped head, inhabitants, lethargy, and seizures. It can be sporadic or inherited.
What else?
There are rare neural tube defects, like anencephaly or exencephaly, involving the absence or exposure of the forebrain. Hydranencephaly is where cerebral cortical tissue is destroyed and replaced by a CSF-filled sac, causing lethargy, propulsive circling, head pressing, and blindness. And lissencephaly involves an absence or reduction of the normal folds of the brain, causing weakness and difficulty suckling.
When it comes to inherited neurological issues, I know there's one specific type of epilepsy that gets a lot of attention in certain breeds.
You're thinking of juvenile idiopathic epilepsy, or JIE,
Right.
and it's quite unique. This is actually the only well-characterized epileptic syndrome identified in large animals.
Really? The only one?
The only one well-defined so far.
Mm.
It primarily affects Egyptian Arabian foals.
Specifically Egyptian Arabians.
Primarily, yes. Seizures typically start from 2 days to 6 months of age, with a median onset around 2 months.
And what do the seizures look like?
Characteristically, these are sudden, generalized tonic-clonic seizures that involve stiffening, tonic, and then rhythmic jerking, clonic, often with loss of consciousness, and interestingly, without those subtle preictal signs we mentioned earlier.
So they come on suddenly.
Very suddenly. Postictally, after the seizure, you might see cortical blindness, disorientation, altered behavior, or difficulty swallowing. But the key distinguishing feature, and what gives it its name, idiopathic meaning unknown cause, juvenile meaning young, is that affected foals are otherwise clinically and neurologically normal between seizure episodes.
So if they're normal between episodes, what's the long-term outlook for JEE? Does it go away?
The prognosis for JE is generally favorable. It's typically self-limiting. With spontaneous resolution, the seizures just stop, usually by 1 to 2 years of age.
That's good news. And it's genetic.
It has a clear familial basis, suspected as autosomal dominant inheritance. The repeated identification, specifically within Egyptian Arabian foals, strongly indicates a breed-specific genetic predisposition.
And this has wider implications.
It does. This positions JIE in foals as a valuable natural animal model for studying similar self-limited epilepsies that occur in human infants. It offers opportunities for learning in both human and veterinary medicine. We should also briefly mention lavender foal syndrome, another genetic issue primarily in Egyptian Arabians, and that hyperammonemia we talked about earlier, which can affect Morgan foals as other inherited conditions.
So the prognosis for congenital issues can really vary wildly. JIE sounds hopeful, but some of those malformations, not so much.
Absolutely. While JIE has a favorable outlook, many other severe congenital brain malformations often carry a poor prognosis for future athletic performance, frequently leading to euthanasia. This highlights the critical need for careful, realistic prognostic discussions with owners. Advanced imaging, especially MRI, magnetic resonance imaging, is crucial for accurate diagnosis and prognosis in these cases.
And the full brain itself is different, right?
Yeah.
Affecting how seizures look.
Yes, it's worth noting the unique neurophysiology of the neonatal brain. There's an early maturation of excitatory circuits, the go signals, and a delayed maturation of inhibitory circuits, the stop signals. Plus, their nerve fibers are still developing their insulation, called myelination.
How does that change things?
It means seizure patterns can be less propagated, less likely to spread widely, and more fragmented in foals. This can lead to a higher frequency of specific neonatal signs like repetitive mouthing or abnormal eye deviation, rather than always the big generalized seizure. This implies specialized expertise is needed for interpreting findings from tools like EEG and for assessing clinical signs accurately in foals. You can't just extrapolate from adults.
So with all these intricate possibilities, from infections to inherited conditions to toxins, how do vets even begin to pinpoint the exact cause in these fragile foals? It sounds like it demands a systematic, almost detective-like approach.
It truly does. It's all about being systematic. It all starts with a clinical evaluation, and obtaining a detailed history is absolutely crucial. Often, this is the first and most vital step in identifying the underlying cause.
What kind of history? What are you asking?
Key areas of inquiry include details of the birth itself. Was it difficult? Dystocia? Was there a red bag delivery? Was labor-induced? C-section? Maternal factors? Any illnesses the mare had during pregnancy? Her nutritional status? Fetal factors? Was it a twin pregnancy? Any known malformations? Umbilical cord issues?
And after birth?
Then, the postnatal environment and any potential exposures, toxins, infectious agents, sanitation. We also need very detailed observations of the clinical progression. How did the foal's behavior change over time? How vigorous was its nursing? And importantly, the specific characteristics of the seizures. When did they start? How long did they last? How frequent were they? Along with the mare and foal's vaccination history.
So the investigation starts before even touching the foal.
It really does. This reinforces that the diagnostic process begins long before any physical exam or lab test. A comprehensive, accurate history, ideally from the primary caretaker who sees the foal most, is fundamental for establishing a presumptive diagnosis and guiding all the further tests.
Okay, and after that detailed history, what's involved in the physical exam for a seizing foal, keeping those neonatal differences in mind?
Next is a comprehensive neurological examination. While it shares similarities with examining adult horses, there are really important age-specific differences to remember. Vets observe general behavior, consciousness level, and spontaneous movements, looking for things like lethargy, disorientation, that aimless wandering, inappropriate behavior, or even abnormal vocalizations like barking.
And specific reflexes.
Yes, they assess cranial nerve function. This includes the menace response, that blink reflex when something quickly approaches the eye. It's actually a learned reflex in foals and typically develops around 7–10 days of age, so its absence in a very young foal isn't necessarily abnormal. But the suckle reflex is critical. That should be present and strong within about 20 minutes of birth. Pupillary light reflexes might also be a bit slow in newborns.
So a foal's reflexes might be different from an adult horse. That's a really good point for a vet to remember.
Absolutely vital. Posture, postural reactions, and gait are also evaluated. Foals are surprisingly coordinated right at birth, so any clear ataxia, wobbliness, or hypermetria, exaggerated goose-stepping movements, is significant.
And spinal reflexes.
Segmental or spinal reflexes are often hyperreactive in foals compared to adults. Strong extensor rigidity and a crossed extensor reflex where stimulating one limb causes extension in the opposite limb are common and normal in the first 3 weeks.
So knowing what's normal for a foal is key to not misinterpreting things.
Exactly. This is vital because it means vets need specialized knowledge of normal neonatal development to avoid misinterpreting physiological immaturities as pathological signs. This specialized understanding is critical for accurate diagnosis. And of course, safety is paramount during the exam due to potentially unpredictable violent movements. A padded environment and adequate assistance are necessary.
Okay, once the history and physical exam are done, what are the crucial lab tests that vets rely on to dig deeper?
Then we move to laboratory diagnostics. These are indispensable for identifying the cause, assessing any systemic involvement, and guiding therapy. Blood work, including a complete blood count, CBC, and serum biochemistry panel, provides crucial information.
What can the CBC tell you?
The CBC can indicate systemic inflammation or infection with changes like leukopenia, low white blood cells, or leukocytosis, high white blood cells. Low platelet counts might suggest intracranial bleeding risk. Mild anemia might indicate chronic inflammation.
And the biochemistry panel, that sounds like where you find the metabolic clues.
It's a treasure trove, yes. Glucose levels. Hypoglycemia is common, though remember the source variation we noted, and hyperglycemia is also a bad prognostic sign. Calcium and magnesium, low levels directly induce seizures. Liver enzymes. Kidney parameters, elevated creatinine, hypercreatinemia at admission is linked to increased NE mortality. Ammonia and bile acids for liver function, especially looking for portosystemic shunts. Electrolytes, sodium, potassium, chloride, where imbalances, especially rapid changes, can profoundly affect brain function.
Anything else in that panel?
Acute phase proteins like fibrinogen or serum amyloid A, SAA, indicate inflammation or infection. And immunoglobulin G, IgG levels, are crucial to determine if there's been a failure of passive transfer, FP, from the mare's colostrum, which significantly increases susceptibility to sepsis and subsequent CNS infection.
Your blood work gives a broad snapshot of what's going on systemically.
Exactly. These lab findings act as early indicators of systemic illness impacting the CNS, sometimes even before overt clinical signs appear. Routine, comprehensive blood work is a rapid and essential screening tool.
And what about fluid from around the brain? CSF taps. I've heard that can be incredibly informative for infections.
Yes, cerebrospinal fluid, CSF analysis, is considered the most reliable and accurate means of definitively identifying meningitis or encephalitis inflammation within the CNS.
How is that collected and what do you look for?
Vets collect samples carefully from specific spaces, either at the back of the head, atlanto-occipital space, or sometimes the lower back, lumbosacral space. Normal CSF should be clear and watery. Abnormalities are revealing. Red or brownish discoloration suggests hemorrhage. Yellowish xanthochromia can mean older hemorrhage or jaundice, while turbidity or a grayish-greenish hue indicates pus or infection.
And you look at cells and protein.
Yes. An increased white blood cell count, or pleocytosis, indicates inflammation or infection within the CNS. Different cell types point towards likely causes. Neutrophils often suggest bacterial or fungal infection or even early EE, while mononuclear cells are more common in chronic viral or fungal infections. Increased protein concentration is also common in inflammation, and decreased glucose compared to blood glucose can suggest bacterial meningitis as bacteria consume glucose.
Can you test the CSF for specific bugs?
Absolutely, specific pathogen testing on the CSF, like PCR for bacterial or viral drRNA, is vital. For protozoal diseases like EPM, we often look at serum to CSF antibody ratios. CSF analysis provides direct evidence of inflammatory or infectious processes right there in the CNS, which is invaluable for guiding targeted therapy.
Are there downsides or limitations?
Well, blood contamination during the collection can complicate interpretation, and sometimes, especially early in a disease process, the CSF can look normal even when there is disease. So a normal tap doesn't always rule everything out.
And if you suspect a toxin, you'd be looking for that specifically in the lab, right? Sending off different samples.
Precisely. When toxin ingestion is suspected, toxicological screening is highly recommended. Samples might include feed, water, suspected plants, blood, stomach contents, even feces or urine, depending on the suspected toxin.
And again, the need for repeated tests.
Yes, it bears repeating. The dynamic nature of metabolic derangements in critically ill foals necessitates serial monitoring of blood parameters like electrolytes and glucose. They can change fast. This proactive monitoring is key to preventing recurrence of metabolically induced seizures.
What happens when the clinical evaluation and basic lab work don't give a definitive answer? When the mystery is still unsolved, or you need to see the structure of the brain?
That's when we turn to advanced imaging.
So like CT scans and MRIs, just like in humans.
Exactly. Computed tomography, CT, and magnetic resonance imaging, MRI, provide detailed anatomical information about the brain and surrounding structures.
What's the difference? When would you use one versus the other?
CT is very valuable for identifying skull fractures, acute intracranial hemorrhage, that fresh bleeding inside the brain, and bone infections. Its rapid acquisition time, the speed of the scan, makes it particularly beneficial in emergency settings or with foals that are hard to keep still.
And MRI?
MRI, on the other hand, offers superior soft tissue detail. It's generally preferred for looking at the brain tissue itself, the parenchyma, detecting subtle lesions, cerebral edema, brain swelling, tumors, abscesses, and congenital malformations.
Are these always able to find the problem? If a foal has neurological signs, will an MRI always show something?
Unfortunately, no. It's somewhat surprising, but despite their incredible capabilities, MRI may show no visible abnormalities in up to 70% of neurological cases in horses, even when there are severe clinical signs. This really highlights the need for other diagnostic tools and maybe even more advanced imaging methods in the future.
So they're useful but not foolproof.
Right. CT and MRI offer complementary information. Sometimes combining them or selecting the most appropriate one based on the initial suspicion is crucial for a comprehensive diagnosis.
And what about actually confirming seizure activity itself? Is there a gold standard for that, for seeing the abnormal electrical activity?
The definitive diagnostic tool for confirming seizure activity itself and characterizing it is electroencephalography, or EEG, recording the brain's electrical waves.
Like they use in human epilepsy.
Exactly. This is truly the gold standard for identifying where epileptic activity originates and how it spreads within the brain. It's essential for accurately classifying conditions like juvenile idiopathic epilepsy we talked about.
Is EEG widely available for horses?
Its availability is still somewhat limited in general veterinary practice, but it's becoming increasingly accessible in referral centers and universities.
It sounds like technology is constantly improving the diagnostic toolkit.
It really is. What I find exciting is that ongoing technological advancements, larger CT scanners that can fit more of the horse, higher strength MRI systems giving better resolution, and the development of standardized EEG protocols for horses continue to improve diagnostic accuracy and capabilities. This offers more hope for understanding and treating these young patients.
Okay, so once we've hopefully pinpointed the cause, or at least narrowed it down, what's the plan to help these foals? Treatment sounds like it has to be multifaceted, focusing not just on stopping the seizures right now, but also on preventing further brain damage.
Absolutely. The immediate priority for an actively seizing foal is emergency management, and that starts with safety measures.
Protecting the foal from injury during the seizure.
Exactly. This means removing any potential obstacles from their area, providing deep bedding or even padded walls if possible, sometimes careful physical restraint by a human holder just to prevent violent self-injury, and maintaining a quiet, dark environment to minimize stimuli that could trigger more seizures.
And for the seizures themselves, what medications do vets use to stop them quickly?
Then comes pharmacological intervention with anticonvulsants, usually given intravenously for rapid effect to control the seizures.
What are the go-to drugs?
Rapid-acting options like diazepam, Valium, are often first line for quick control. It works fast, but its duration is short. Also, it's light-sensitive and can be inactivated by plastic syringes or IV lines, so careful handling is critical.
Good to know. Any others?
Midazolam, Versed, is another first-line benzodiazepine, similar action to diazepam, and it can be given as a continuous rate infusion, CRI, for more sustained control.
What if the seizures are severe or keep coming back?
For longer-acting control, phenobarbital is crucial, especially for severe or recurrent seizures. It usually requires a loading dose intravenously to get therapeutic levels up quickly.
Are there downsides to phenobarbital?
Yes, it requires careful monitoring of liver function, blood counts, CBC, and serum drug levels because it can potentially cause hepatotoxicity, liver damage, and bone marrow dysfunction with long-term use. Also, it shouldn't be stopped abruptly. It needs to be tapered off.
Any other long-term options?
Potassium bromide, KBR, can be used as an add-on therapy, often with phenobarbital, but it has a very long elimination half-life, meaning it takes weeks to months to reach a steady-state concentration in the body, although a loading dose protocol can accelerate this. We need to monitor serum bromide levels, and side effects can include increased appetite, sedation, and ataxia, wobbliness.
What about some of the newer drugs used in humans? Are they used in foals?
Yes, levetiracetam, Keppra, is increasingly used. It's a human medication that's attractive because it acts rapidly. It's primarily excreted by the kidneys rather than the liver, which means fewer drug interactions, and it generally has a good safety profile.
Any drawbacks to levetiracetam?
It has a shorter half-life in horses compared to humans, meaning it might need to be dosed more frequently, and tolerance where the drug becomes less effective over time can sometimes develop.
It sounds like choosing and using these drugs requires real expertise.
It absolutely does. The choice and monitoring of these anticonvulsants demand a nuanced understanding of their unique pharmacokinetic properties, how the body handles the drug, and their potential side effects. Things like the instability of diazepam or the liver metabolism of phenobarbital are critical considerations. Loading doses, while effective for rapid control, require close monitoring for side effects, like profound sedation or respiratory depression.
So just stopping the seizures isn't enough, right? As we discussed with the causes, you have to get to the root of the problem.
Exactly. That's paramount. Effective long-term management fundamentally depends on accurately identifying and treating the underlying cause. Symptomatic seizure control alone is insufficient for a good outcome.
So tailoring treatment to the cause? Like antibiotics for infection?
Precisely. For infections, that means specific antimicrobial therapy based on culture and sensitivity results, if possible. We might use broad-spectrum antimicrobials immediately if sepsis is suspected, while waiting for results. Specific antiparasitic drugs, like pontogerol, are used for protozoal infections like EPM.
And for metabolic issues?
For metabolic derangements, rapid correction is crucial, as we discussed. 4V glucose for hypoglycemia or specific electrolyte supplementation based on serial blood work monitoring.
And for physical brain injuries, TBI.
In cases of traumatic brain injury, treatment focuses on reducing cerebral edema, that brain swelling. Medications like mannitol or hypertonic saline are often used to draw fluid out of the brain tissue. Sometimes surgical intervention might be needed for depressed skull fractures or to evacuate large blood clots, hematomas.
What about the congenital or genetic disorders?
Management might involve surgical shunt placement to drain excess fluid in cases of hydrocephalus. For JI, since the seizures are often self-limiting, long-term anticonvulsant therapy might not be needed, though short-term treatment during active clusters might be used.
And if it was a toxin?
With toxicosis, the primary treatment is immediate removal from the toxin source, decontamination if possible, like activated charcoal, along with supportive care and specific antidotes if available. Those specific antidotes are rare for plant toxins.
It really drives home how important getting the diagnosis right is.
It really does. A precise diagnosis directly dictates the efficacy of the therapeutic approach. It's also worth noting that foals with NE or sepsis are particularly prone to developing secondary infections, like pneumonia, so prophylactic broad-spectrum antibiotics are often warranted in those cases.
Beyond the specific treatments for the cause, what kind of overall care is crucial for these critically ill foals? You mentioned neuroprotection.
Yes, Crucially, neuroprotection strategies are paramount regardless of the specific cause. These focus on minimizing or preventing that secondary brain injury cascade we talked about.
How do you do that?
A major component is maintaining physiological homeostasis, keeping the body stable. That means ensuring adequate blood pressure to perfuse the brain, maintaining normal blood glucose levels, ensuring stable body temperature, and providing optimal tissue oxygenation. All of this is critical for supporting cerebral blood flow and preventing further ischemic injury. So treatment actively involves mitigating ongoing cellular damage.
And general supportive care, nursing.
And finally, comprehensive supportive care is truly a cornerstone of management. It's often as critical as, or even more critical than, the specific treatments. This includes meticulous general nursing care.
Like keeping them warm and clean?
Exactly. Maintaining a warm environment using blankets or heat lamps to prevent hypothermia, which neonates are prone to. Frequent turning every 2 to 4 hours for recumbent foals to prevent pressure sores. Strict hygiene, especially umbilical care, to prevent ascending infections and sepsis. Lubricating the eyes frequently and checking for corneal ulcers, which can happen easily if they're rubbing their face or not blinking properly.
And respiratory support. You mentioned aspiration pneumonia earlier as a risk.
It's a huge risk, especially if they have difficulty swallowing. Respiratory support might include ensuring adequate oxygenation, perhaps with humidified oxygen delivered via nasal cannula. Mechanical ventilation might be needed in severe cases. And crucial prevention of aspiration pneumonia involves careful management of feeding, potentially elevating the head, suctioning the airway if needed, and often prophylactic antibiotics.
Nutrition must be vital, too, given their low reserves.
Absolutely vital. Nutritional support is paramount given foals' minimal glycogen and fat stores.
How is that usually given?
Enteral nutrition feeding into the gut is preferred if their GI function is adequate. This usually means mare's milk or a milk replacer given via a nasogastric tube, typically in small, frequent feeds to mimic natural nursing.
And if their gut isn't working?
If the GI tract is immature or dysfunctional, ileus, then parenteral nutrition is necessary. This could be partial, IV dextrose and amino acids, or total parenteral nutrition, TPN, providing all necessary nutrients intravenously.
Any other supportive therapies often used?
Gastrointestinal protectants, like anti-ulcer medications, omeprazole, sucralfate, are often used prophylactically in stressed or hospitalized foals as they're prone to gastric ulcers. Antioxidant therapy with things like vitamin E, vitamin C, or DMSO might be used to try and mitigate free radical injury, though evidence varies.
I saw one source mention something called the Madigan squeeze.
Ah, yes, the Madigan foal squeezing method. This is a novel supportive therapy that's gained attention for foals with suspected NE or maladjustment. It involves applying firm but gentle pressure around the foal's rib cage with ropes for about 20 minutes, trying to mimic the pressure of the birth canal.
And the theory is?
The theory is that this pressure helps transition the foal from the in utero neuroinhibited state to wakefulness, possibly by altering neurosteroid levels. Some reports suggest it can improve awareness and suckling response. However, it's crucial to emphasize it should only be done under veterinary supervision and isn't appropriate for all cases.
Fascinating. It really shows how supportive care covers so many bases.
It does. Comprehensive supportive care is foundational for improving prognosis. It acknowledges that neurological health is intricately linked to overall physiological stability. Proactive measures to prevent secondary complications like pneumonia, sepsis, or physical trauma are vital for improving survival and long-term functional outcomes. And the unique nutritional nuances of neonates require careful, dedicated management to support brain function and prevent metabolic crises.
So once a foal have gone through all this, the seizures, the diagnostics, the intensive treatment, what's the long game here? What does the future look like for these foals? The prognosis for foals experiencing seizures sounds like it can be highly variable.
It really is. The specific cause, the etiology, is a primary determinant of the prognosis.
Can you give some examples based on the causes we discussed?
Sure. For neonatal encephalopathy, NE, assuming it's uncomplicated by severe infection or other major issues, the prognosis is generally fair to good. Studies suggest around 80% of foals with NE can recover and potentially go on to have athletic careers, especially if intervention is prompt.
That's quite hopeful. And JIE?
Juvenile idiopathic epilepsy, JIE, as we discussed, has a favorable prognosis. It's typically self-limiting, with the seizures resolving spontaneously, usually by 1 to 2 years of age, and foals are normal between episodes.
But other causes are far more serious, I imagine, in terms of outlook.
They often can be, yes. Bacterial meningitis or meningoencephalitis generally carries a poor to grave prognosis. mortality rates are high, and even survivors may have significant residual neurological deficits.
And head trauma, TBI.
Traumatic brain injury is variable. One study in a referral population showed around a 62% survival rate, but it depends heavily on the severity and location of the injury and the presence of secondary complications.
What about the congenital brain malformations?
Many severe congenital brain malformations unfortunately carry a poor prognosis for future athletic performance or even just a good quality of life, frequently leading to euthanasia.
Does how bad the seizure is or how the foal presents initially tell us anything about their chances? Clinical signs as indicators.
Yes, the severity of clinical signs definitely matters. Generalized, severe, or recurrent seizure activity that's difficult to control is generally a poorer sign. Profound mental depression, stupor, or coma is also associated with a poorer prognosis. Specific factors like being recumbent, down at admission, having hypothermia, low body temp, and hypoglycemia, low blood sugar, have all been significantly linked to higher mortality rates, particularly in foals with NE.
And how well they respond to treatment.
Yes, the response to treatment is key. Early, timely, and aggressive veterinary intervention significantly improves the prognosis across most causes. Delay allows more secondary damage to occur.
And if there are other health issues on top of the seizures, comorbidities.
That's a huge factor. The presence and severity of concurrent illnesses profoundly impact the outcome. Sepsis and pneumonia are particularly relevant comorbidities that drastically worsen prognosis.
How drastically?
For instance, one major study found that foals with NE that developed pneumonia or sepsis during hospitalization faced over 40 times greater odds of mortality compared to those that didn't.
Wow, 40 times. That's staggering.
It really highlights the crucial need for comprehensive monitoring and prophylactic measures to prevent these secondary infections in vulnerable hospitalized foals.
And even if they survive, are there often lingering problems?
Yes, even among survivors, long-term neurological deficits can occur, impacting future quality of life and athletic performance. These may include residual cortical blindness, disorientation, abnormal gait or ataxia, muscle atrophy or paralysis from nerve damage, and other forms of residual neurological dysfunction.
So owners need to be prepared for that possibility.
Absolutely. Owner counseling must include a realistic discussion about these potential lasting effects, not just survival odds.
It sounds like the earlier the intervention, the better the chance of not just survival, but a good functional outcome.
That's the take-home message. The prognosis is generally much more favorable with prompt diagnosis and aggressive supportive care, especially for conditions like NE, where recovery potential is good. Conversely, any delay in treatment significantly worsens outcomes, as secondary brain injury can rapidly progress and become irreversible. This highlights that the window for effective intervention is often narrow.
And it brings up an important distinction, doesn't it? Survival versus function.
It really does. This raises an important question for you and how you think about animal care. There's a critical distinction between a foal's survival and its complete functional recovery. While many survive seizure events, especially with intensive care, a significant proportion may live with residual neurological deficits that impact their future quality of life and intended use.
So looking forward, what are the big areas where the field is still learning, still pushing boundaries when it comes to foal seizures? Where does research need to go?
Foal seizures remain a complex and urgent challenge, requiring that multimodal, integrated approach we've discussed. Looking to the future, several key areas warrant continued research and development.
Like better diagnostics.
Definitely. We need novel diagnostic biomarkers, perhaps things measurable in blood or CSF, for earlier detection of specific conditions like NE, and for providing a more accurate prognosis early on. Advanced genetic testing for inherited epilepsies like JAE will improve diagnosis, allow for better genetic counseling for breeders, and potentially even open doors for targeted therapies in the future.
And I imagine new treatments are always on the horizon, or at least hoped for.
Yes, there's a great need for innovative therapeutic interventions. This includes potentially new anticonvulsants with better efficacy or safety profiles in foals, more effective neuroprotective agents to shield the brain from secondary injury, and perhaps targeted therapies based on a deeper understanding of those specific pathophysiological mechanisms we discussed for conditions like NE or meningitis.
And learning from foals to help humans, and vice versa.
That comparative medicine angle is really important. The study of naturally occurring foal neurological disorders, especially those with parallels to human pediatric conditions like JIE, offers valuable opportunities for reciprocal learning and accelerating advancements in both fields.
Standardization seems important, too, for comparing studies.
Absolutely. Establishing standardized EEG protocols and universally accepted seizure classification systems specifically for veterinary medicine will enhance research comparability and improve clinical communication between vets. Ultimately, this leads to more precise diagnoses and more tailored, effective treatment plans.
What an incredible journey we've taken today. We've really delved deep into the intricate world of foal seizures, from the immediate drama of the event itself to the hidden complexities of the neonatal brain, that wide array of potential causes, the meticulous diagnostic detective work, and the multi-layered strategies for treatment and long-term care.
It's a huge topic. And when you consider the intricate challenges faced by these tiny foals and how understanding their specific conditions like NE or JIE can actually provide profound insights into human pediatric health, well, it truly makes you ponder, doesn't it?
How so?
How much does our diligent care for animal health not only save lives in the barn, but also profoundly expand our understanding of the most fragile moments of life, even in humans? It's a remarkable connection, that comparative aspect, and it continues to evolve. It really prompts us to always keep digging, always keep learning,